Morning, everyone, and welcome. My name is Laura Conn, and I'm Deputy Director for Engagement, Insight and Evaluation, and I will be facilitating today. Before I ask my CQC colleagues to introduce themselves, I want to cover some housekeeping and what we can expect in today's session. So the way this session is set up, only Toli, myself, and other CQC colleagues will be able to use their camera and microphone. We have a dedicated Slido session coming up, but if you have any general questions or need clarity on anything, please use the Q&A function to post your question. And when posting a question, please use your name. This event will be recorded and we will be sharing the slides and recording with you. We recognise that the last few years have not been easy, and we've heard from many of you about the challenges you have faced. We know we need to improve, and the purpose of this session is to do just that, to look forward, collaborating with you to shape how we work in the future. This session is not intended as a space to discuss individual concerns or issues, and we respectfully ask that you keep this in mind throughout the session. We're really keen that everyone in the session has a positive experience, so please approach today without judgment, be respectful of the diverse range of experiences, skills, knowledge and contributions of those on the call today. Support one another to get involved in the Q&A chat and ensure you upvote comments and questions you'd like us to come to later on. Moving on to what you can expect today. There will be a presentation from Toli focused on improving how we assess and rate providers. After that, there'll be an opportunity to ask questions, an interactive Slido session, and a live summary of what we've heard before moving on to next steps. I'll now pass on to other CQC colleagues on the call to introduce themselves, starting with Sarah.
Hi everyone, my name's Sarah. I am a Deputy Director of Campaigns in our engagement team.
Thanks, Sarah. Moving to Jay.
Hi everyone, my name's Jay Harmon. I sit in the campaigns team and I have a lead for our public campaign activity, Share for Better Care, which we run with Healthwatch England and other charity partners to encourage people to share their experiences of care.
Thanks, Jay. Matthew. Oh, you're on mute, Matthew.
Oh, sorry. Hello, good morning, everyone. My name is Matthew Knight. I'm a Senior Experts by Experience Officer working for Engagement, Insight and Evaluation.
Thanks, Matthew. Ruby.
Hello everyone, my name is Ruby Okoje. I am a Policy Manager in our Acute and Mental Health Policy team, and I lead on our Acute Trust methodology.
Thanks, Ruby. Maria.
Good morning, everyone. My name is Maria Stamanova, and I am Policy Manager at the Acute and Mental Health Policy team, and I work on the improvement of the assessment framework for the acute sector. Thank you.
Thanks, Maria. And Toli, I will now pass to you to introduce yourself and move on to your presentation.
Brilliant. Thank you very much, Laura. Good morning, everybody, and huge thanks to you all for giving up your time this morning to join us on this webinar. We recognise how busy everybody is, in the world of providers, and we really appreciate you taking the time to join us. I'm sorry that numbers are so big that we've had to do it in this format, but it's just wonderful that numbers are so big and we will get really rich feedback from you. I'm Toli Onon. I'm Chief Inspector of Hospitals at CQC, and I've been in the role just short of 3 months now. So while I'm delighted to be here and absolutely now a regulator, so much of my formative experience has come from being a provider. I've worked in healthcare for 35 years before joining CQC. I was consultant in obstetrics and gynecology in Manchester and joint chief medical officer at the big trust there. So that's very much in my formative years and in my character. And of course, all of us on this call are users or potential users of services, as are our loved ones and our friends. And I think we're all motivated by our duty, to our public. So we've just got a presentation to run through about our workshop today, and we're coming at it from the perspective of our sector, which is hospitals, secondary and specialist care. So if I might have the next slide, please. Thank you. And it really is, thank you, about how we assess and rate our providers. In terms of the vision that the CQC has is the same vision that I think all of you as providers and our service users have, which should be that in this country, everybody receives safe, effective and compassionate care. And we just come at that common vision from different angles. So as the regulator, we have to work with the public who support us and at whose pleasure we exist, basically, and work with systems and providers to protect patients and service users, but also as the regulator to support improvement. Next slide, please. And as Laura said, we're aware that, we've had problems in recent times and we have not served our public and our providers as best as we could have. And therefore, the mission very much is to rebuild a trusted approach to regulation. And there are sort of 5 routes through which we're doing that. So clearly, leadership and expertise matter. And that has driven the move back into sectors. So, of course, I'm delighted to be talking to you in the context of the hospitals and specialist and secondary care sector. But we have our adult social care, our mental health, our primary and community sectors. And the value of that is that specialised knowledge we'll bring to it. But of course, the risk is that we must not fall into silos, because of course patients and service users don't just seek care from one sector. Their pathway runs across all 4 sectors. So we need to be sure that we get the benefits of expertise without becoming siloed. We know that we've had a backlog in registration, and that's affected the hospital sector much less. It's particularly been a problem, for adult social care. And the registration there is so important because of the ability to provide the service. And registration isn't just an administrative process, it's really the first assessment of a service, so it is key. We're here today to talk about how we review the assessment framework, and we're so thankful to you all for making the time to join us, because it's your feedback that will help us get this right. Part of our rebuilding is to review how we undertake our inspections and how we best use data and technology to be more insightful. And as we've said, it is key that we work in partnership. We want to do this right, and we can only do it right through working in partnership. Next slide, please. So one of the issues around having a review of our assessment frameworks is that we want to go back to sector specific and sector differentiation assessment frameworks. We recognise we cannot regulate in a generic way. We cannot regulate as well as we should in a generic way. We can regulate better by being more sector specific, but ensuring that we're joined up between sectors and ensuring consistency in how we regulate. We've talked about our registration function, and of course, regulation is to identify breaches of the fundamental standards and to support improvement, as well as the enforcement element of that. We've talked about recognising the different types of organisations, but also I think the need to be cognizant of the changes that are happening. So we're seeing changes with the NHS 10-year plan. We're seeing changes in professionalism of how care is delivered. For example, I've just had a call with the BMA, who remain concerned about how we ensure that the right types of professionals are providing care. And we have to be future-proofed in a world that's changing quite rapidly. And ultimately, regulation has to work for people who use the services. It's important for providers, it's critically important, ultimately important for patients and service users. And so those really are our priorities around that. Next slide, please. The case for change at the CQC is strong. Those of you who have been close to it will be aware of the independent reports last year undertaken by Penny Dash into the function of CQC, and of course the report that Professor Sir Mike Richards produced around the assessment frameworks. He was Chief Inspector of Hospitals in what was something of a golden age of the CQC, when all providers were assessed and there were not the concerns about consistency and so on that we're seeing now. And those reports have been very influential in us being here all together today. The Care Provider Alliance is an alliance of providers of adult social care, and again fed back an influential report. And as I've alluded to, the NHS 10-year plan is really talking about very different models of care, and we, the regulator, have to be confident that we regulate provision of care in accordance with those new models in a way that improves services for patients. Many of you will also be aware that CQC commissioned an independent review of its IT systems and the implementation of its regulatory platform that has not succeeded in the way that it was hoped. So we will have a big piece of work which has already kicked off to develop a new platform, but the fine detail of that platform is really dependent on what we agree around the assessment frameworks. So depending on what assessment looks like, that will inform then what the platform looks like to support it. And the huge amount of feedback that the CQC has had from within our sectors, from within our organisation, from the public, has been invaluable. All of this took place before I joined the regulator. So I would like to say, not as part of the regulator, how much I admire the CQC's openness and honesty about its problems. As I say, that took place before I joined, so I'm not blowing a trumpet of which I was any part. I just think they set a great example of acknowledging when things have not gone well and being really open and honest and proactive about wanting to improve. Next slide, please. So a big part of how we improve is this consultation into our assessment frameworks. And that is, what we want your feedback upon. Really, how do we go about our process of inspection, the assessment, the ratings, the overall publication of our reports and engagement with providers and patients? We truly want that feedback. We want this to be right, and it cannot be right if it's only undertaken by CQC. Next slide, please. So these are some of the things that we believe will strengthen the assessment framework, but that's where we welcome your feedback and your ideas. We're proposing to reintroduce rating characteristics. So what I mean by that is a description of what does good look like, and then also what does outstanding look like, what does requires improvement look like, and what's inadequate look like. So we'll start with what does good look like, but having those descriptions we believe will be helpful to providers. Many of you will be aware that we've been using quality statements as the basis of our assessment, and again, feedback is that these could be better. And therefore, the question that we are proposing is, should we be going back to actually asking questions similar to our previous key lines of inquiry? The content of those quality statements is good, but it's really turning the statement into more of a question, like the previous Chloe's. Would that be helpful to providers? And we also want to reintroduce sector-specific assessment frameworks. So I talked about how we'd been more generic before. Generic, actually, we believe will be better if we go back to being sector specific, with the benefits of understanding a sector through the assessment framework, but also, as I say, having strong links between sectors so that we aren't siloed in our regulation. But that would mean being specific for our sector, hospitals, detailed guidance so that it feels more relevant. And we would do that through further engagement and absolutely co-designed with the sector. And we recognise we need to simplify and clarify the frameworks. Things got very complicated, have got very complicated, with 34 quality statements, 6 categories of evidence, scoring, and we recognise that that isn't necessarily the best way of doing this. Next slide, please. So we really want feedback on how we assess providers and how we award the ratings. We want to return to making the judgments at the level of the 5 key questions: safe, effective, responsive. I'm sorry, the door's rattling here. Oh, so sorry. Real life in a provider. So we think that would be valuable to providers, and say to no longer have these scores that we have been using at present. And we will improve our ways of working. We will improve the quality of our reports. Our IT system will mean that we can produce those reports for publication more rapidly. And we have a program to induct, upskill, and continuously professionally develop our inspectors and increase the amount of specialist advisor input we have from clinicians of all types. We also want to rebuild stronger relationships with providers. Now, I know there was an excellent system historically of relationship managers, and I'll just tell you this as an anecdote. I was surprised at how in some parts of the country that had been so badly impacted. I say I was surprised because as a provider in the north of England, that was maintained in the north, and I think we were protected from that impact. So for me to learn how impactful it has been in other parts of the country to lose that, I was sort of really surprised, because we hadn't seen that loss in the north. We were very fortunate with that, because I think providers do value that relationship management, and certainly as CQC we value that. Next slide, please. So we do believe that we need to reform this. And one of the key things that we will be asking you, particularly as NHS trusts, because it's applicable in that context, is about whether we should reintroduce the overall quality rating for trusts that currently has gone. We just do the well-led now at trust level. So should a trust have an overall quality rating, and should it also have overall trust level ratings for safe, effective, responsive, and so on? And this bullet point here is quite a complex one, on around location ratings for individual hospitals within an acute trust. So what do I mean by that? Our assessment framework for our sector has to work for a provider, whether that provider is a standalone specialist provider or a small district general providing key services to its local population, or a big group of hospitals providing local and tertiary services. That framework has to work for all of those providers. But for example, at the moment, in a big group provider with 3 type 1 emergency departments, we will rate by location, and that is meaningful to patients who use a particular location. That provider might also provide care in 3 maternity units, but manage that care right across all 3. Would it be more beneficial to that provider and service users to have one set of ratings rather than location based? So this is feedback that we would value from yourselves. What works for providers and what works most importantly for the patients and service users? Next slide, please. So overall, we recognise that through better regulation, we can indirectly support better care, provided that direct providers, of course, but we can support improvement. And this consultation is key to get the views of the public, providers, service users on how we can best do that. We've had great response. We've had nearly 1,000 responses now as of the 25th of November. And we want more. We will publish that feedback. We will look at it all. We will respond to it and publish it probably early in the new year. Next slide, please. So you can submit feedback up to the 11th of December, and we have a QR code. Next slide, if you will. We have a QR code and through our website as well at cqc.org.uk. We will, of course, next slide, please, be undertaking an equality impact assessment. And one of our Slido questions today, we touch on this a bit further as well. So may I check if we have any specific things we need to respond to now? Any questions? So sorry, let me pull that up. So this is a question about consistency. When the performance of inspections varies significantly, and a question about when inspectors are not expert in the specialty. So that's a really important question, and it's a really important issue that concerns us as well. So thank you for flagging that. So in order to be credible, we have to be consistent as well. And I think there will be a number of different ways in which we will achieve that consistency. It stems from clarity around the framework and the ratings characteristics and the information that we provide to our inspection teams in terms of the guidance. I think it's critical that we have specialised clinical input on every inspection. So we have specialist advisors, but we need more specialist advisors, and we will be coming back to providers asking for your support with that. So we have some really excellent specialist advisors, but we need more for every service that we inspect, because as you rightly say, the inspectors don't have that specialist knowledge in every area. And then we also have quite a strong, detailed quality assurance process for looking at reports before publication, and we need to ensure that that quality assurance process is optimised and applied across all our regions so that we do have that consistency that you describe. Thank you.
There's also a question from Louisa around the scoring system for quality statements or CLOEs. Are we likely to see more frequent inspections for services that requires improvement? I'm not sure if that's one for you or for policy colleagues.
So policy, please do come in for that. We don't want to score anymore is what we're proposing. But yeah, let's bring our policy colleagues in. Thank you.
I'm happy to jump in there. So as Toli has said, we are proposing removing the scoring part of this. In terms of frequencies, as we are looking at what changes we want to make to our methodology in terms of how we assess and how we inspect. Part of that is also thinking about what does the frequency of inspections and assessments look like? What does this mean in terms of how a provider is rated? What does it mean in terms of how we respond to risk, and also how we can encourage improvement as well? So there is something about thinking about what are the considerations that are part of this, and that is definitely something that we're looking at.
Thank you, Ruby. See, there's a couple of other questions. From another one from Amy. Will there also be a standardization of the frequency of inspections for previously highly rated providers?
I think that goes back to what I've just said in terms of considering what our frequencies should look like, and there are a different range of or host of considerations that are part of that. So we are definitely thinking about it, that there are different provider models, that there are different on the scale of where providers sit, there are different aspects, and we need to think about all of those different things in terms of how we can encourage improvement, but also how we ensure that we are responding to risk as well. So yeah, that will all be considered.
Thank you, Ruby. A question from Lizzie. Will you be doing whole hospital site inspections, or will it just be departmental inspections?
I think we need to keep the flexibility, don't we? So I wouldn't want to give a hard answer. It's not an either or. And I think that sort of goes back to what Ruby was saying in relation to risk and so on. Sometimes you have to react to risk in a particular area, but also there will be, indications to do a broader inspection of a provider. So yeah, I think we wouldn't want to make it either or on that one.
Great, thanks, Toli. Another question on CLOEs, which I think might be up for kind of consideration as part of the consultation, but if we return to CLOEs, will they be reduced in number and be less repetitive than they were before, and will they be grouped under quality statement headings?
Yeah, so again, this is why it's so brilliant having feedback, because these are people who really understand the process. Thank you for that. Yeah, so the issue about the repetitiveness, the duplication has come up, and we want to clear that out. This is our opportunity to ensure that we're not repetitive, or that where a question may crop up in different areas, we're expecting, that consistency in that. So I suppose just pops into my head is something like safeguarding. Safeguarding should be pretty consistent in its approach across anywhere in the provider. So we need to be sure that where we're asking that question, that we are consistent in how it's asked, and that we recognise where within a provider there is a consistent response with that, with warranted local variation depending on circumstance.
Laura, I'm happy to come in on that one as well, in addition to what Toli said. So basically what we are planning to do at this point, but obviously there is scope for influencing through the responses that we received to the consultation. Basically the 34 quality statements that we had, the feedback was that there were too many, that there was a lot of repetitiveness, and basically the way that we are approaching this is trying to streamline them, streamlining the topics that are included in the quality statements and rephrasing them. So we're not going back to what we had in terms of key lines of inquiry, but potentially rephrasing the quality statements as questions and prompts so that they're easier to interpret by our inspection colleagues as well as by providers themselves who are being inspected. And definitely that kind of principle of rationalization, of streamlining and removing of duplication is guiding us at this stage.
Thank you, Maria. That's really helpful. Also, can I remind people it's really helpful if you can vote on questions you particularly are interested in us answering, and that will help me kind of prioritise those. One that's got quite a number of votes is, I think, from Charlotte. If scoring is removed, how will providers have the transparency? Knowing if you're a low, good, or closer to outstanding is very helpful. Anyone able to come in on that?
So policy colleagues, come in if I'm misinterpreting anything. So sorry, if scoring is removed, how will we know? Okay, yeah. So it comes back to, again, we've talked within the assessment framework about strengthening the professional judgment, which has to be transparent through the narrative of the reports, but that will play an element, a key element in it as well. So at the moment, the downside of the scoring is the scoring is quite rigid and has not allowed inspection teams to apply professional judgment. Professional judgment's appropriate where it's clearly defensible, defended through narrative, but made by people who really understand inspection, regulation, and the specialty. And that's why we need that specialist advice and the clinical input in the inspection teams to inform that, and then why we need that quality assurance process to validate the consistency of what we're saying. Ruby and Maria, is that fair? Is there anything you wanted to add to that, please?
I think so. I think that's definitely fair to say. I mean, feedback from our stakeholders and our independent reviews have shown that the way that scoring was implemented was a bit too complex. It hasn't worked out in the way that we had hoped it was, and it wasn't actually as transparent enough for providers or the public. So it actually made our ratings judgments a little less clear. So we definitely want to do more work to ensure that we can make sure that the way our ratings are produced are more reflective of the way that care is being delivered and the way people are experiencing care. And also ensure that the way that we make judgment and the way when we publish our reports, it is more transparent and more reflective of what you are seeing in terms of delivery of care and how people are experiencing care as well.
Yeah, I can agree with that, but also add that in addition to being opaque for providers on the receiving end of the scores and the ratings, it has also been difficult to operationalize by our operational colleagues, by inspectors themselves, who have struggled with that very narrow definition of the achievements and the success of the services. And also there are certain quality statements, for example, that wouldn't necessarily work in a specific context, and they would be constrained to score them, which obviously would stifle their whole appreciation of the service, and be quite restrictive in terms of the judgment that they can apply and the overall rating that they can place for that specific key question. Just like Toli said, what we're trying to do here is really put an emphasis on the professional judgment that inspection colleagues can apply, but also support that with narrative, because we have found that scoring is very quantitative in nature, and the qualitative elements in terms of an assessment of the service are equally important. So we thought they need to be captured in a mature way as well.
Thank you, Maria. Another question asking if we're looking at how other countries deliver regulation and inspection as part of these consultation changes.
Yeah, thank you for that. And again, policy colleagues can give more detail around it, but we did link in with King's Fund to undertake a review, and part of their review looked at what goes on in other countries and cited examples of good practice. For example, there are things in Australia that were cited to us. There are also elements of what has been done by CQC, actually, they've been adopted in Europe, even under, single assessment framework. I wouldn't want to give the impression that, everything is not good about the single assessment framework and everything, not at all. There have been elements of that have worked very well and that have been going to, I believe, be adopted or have inspired adoptions in Europe. But I think it's a good question to ask, and we should be doing that. I don't know if Ruby and Maria, if you're any more familiar with the detail behind the King's Fund work, but certainly I know that that they looked at what was done, for example, in Australia.
No, I was also going to mention the King's Fund work, but I don't have as much more to add. But yeah, definitely we do have the King's Fund looking into that and sharing their insight with us, and our colleagues starting to think about where we can make improvements in line with some of that best practice as well.
Absolutely, and the King's Fund work has been really helpful in terms of determining what we should be looking at in terms of outstanding qualities in a service. So those learnings from different countries across the world have informed the advice that the King's Fund has given to us, specifically in particular in relation to outstanding practice and how that can be judged and measured by inspection teams.
Thank you, Maria. And I think we're going to move on to the last question now. And just to reassure people, we won't have a chance to answer all of the questions. We might have some time at the end of the session to come back to them. But anything we don't answer directly now, it's really important for us to still hear that feedback. And we really appreciate you raising it. And we will be reviewing all of that and taking that into account. I'm going to go to this question from Seaton Giles. Please could you expand on how you will ensure that the methodology is followed consistently and that reports across providers and sectors are consistent? We continue to see significant variations in the way the methodology is applied and in reporting. Are you planning on taking a more robust approach to quality assurance, such as adopting ISO 9001 for quality management systems? So I guess this question is more just about the consistency that I think we're looking at as part of the consultation. I'm not sure if policy colleagues or Toli want to come in on that.
Well, absolutely agree with the need for consistency. I think that there's such a key point that you raise that has been sort of fed back to us about that. So I think it goes back to the quality of our framework in the first place, and for, say, in individual specialties, the detail that we put behind that so that inspection teams are well briefed, our consistency in what evidence we seek from providers so that we're comparing like with like, as it were, and then also the specialist knowledge that we get from our specialist advisors. And then, as I say, when you come out of that, going through the QA process, and now that we've gone back to our regions, we have that opportunity as well for the look across regions to assist with that, and I think that will help us greatly.
Great, thanks, Toli. I think, Sarah, am I now passing to you for Slido session?
Yes, thank you. Thanks, Lauren. So if we could just move on to the next next slide, and I'll talk us through how we're going to use Slido. So if you were, you should have hopefully received slides and a link yesterday, but if not, they will be shared again after the session, along with a recording and a summary of everything that we've heard through this next bit and through the Q&A. So if you go to Slido, you can either scan the QR code that is on the screen now, or you can join using the link that is in the chat that was shared at the start of the chat. And if all else fails, you can go to slido.com and put in the code 3287276. So the next, we're going to go through a few different questions to get your views on some of the specific areas of the consultation, and I will share what we are seeing as it comes through, so we can have a bit of a kind of conversation and a reflection around this. So the first question is for any general reflections and comments on the proposals. Can see people are starting to put in answers there, which is really great. If you could indicate the type of organisation that you're from, so whether you're the type of provider organisation, a national stakeholder, or a public representative organisation, that would be great. So we'll just give a bit of time for these to start to come through. Really good here to see that it looks like it's in the right direction. Some thoughts about whether they go far enough. Theme here around consistency. Toli, agreement with your comment around the need to increase SPAs. So I'll just let some of those come through. So generally looking like it's feeling positive and support for the direction. There's one comment here coming through, the move towards subjectivity could surely exacerbate the issues and discrepancies in how the CQC operates cross-departmentally. I don't know if Toli, any reflections on that?
Yeah, again, such an important point, isn't it? Because the increasing professional judgment creates a risk of subjectivity. So we have got to find the balance between the level of professional judgment that is sufficiently credible that people accept it, coupled with the belief that, yeah, and this is consistent across organizations, across regions. We buy into what the regulator is saying. So absolutely get that. And I think that is going to be a tricky balance, and we're going to have to be as intelligent as we can be about it. And that's why we welcome your feedback to help us with that. I just popped a comment in the chat to Sarah, but since I've got the open mic, I'll say it. Please, all feedback is welcome. We know that the very fact of you giving up this time on a Friday morning to join us is because you want to see us develop. So because it's given in that spirit, we welcome it. Give us the good, the bad, the ugly. You know, we want it, and we thank you for it. So please go ahead. Don't hold back.
Thanks, Toli. And second that as well. And that's exactly as you say, Toli, that's the purpose of this session, is to really hear what people are thinking, and appreciate there'll be a number of people on the call who might have already responded to the consultation, and would encourage you to respond if you haven't done, because that does allow for the kind of the more granular detail that we won't necessarily be able to get into here today. But part of today is helping to make sure that people are really clear and understand what the proposals are suggesting, where they've come from and why. And it's also good for us and hopefully for you to see some of the kind of initial thoughts and responses that are coming through. Welcome to going back to sector specific, so that is really great. And as we mentioned, there are moves towards that in terms of the 4 chief inspectors that we have in post, and moving to sector specific teams as well. I will move us on to the next question, but we will leave these open. So if people want to keep adding to them, that is great. Really happy to have those views come through. The next question is thinking particularly about the kind of equality and human rights aspects and the equity in access for people. So we're considering how our proposals might affect some groups of people more than others. So thinking about those people with protected equality characteristics. So, for example, people from different ethnic backgrounds, older people or disabled people. Is there anything that you want to raise about this? So this is thinking particularly about, are there any potential kind of pitfalls that we haven't addressed? We've published an equality impact assessment alongside. What are some of those kind of really core issues that we need to be making sure that we're considering as we kind of develop our approach? Just give some time for those to start coming through. And just while we wait for some of those answers to start coming through, as these might be slightly more detailed than the last question, just reflecting on scoring coming through strongly as a theme as we've been having the discussion so far, and understanding that might be something that is useful for people in terms of understanding where they are on our ratings. So we've got some answers coming through, and first comment is around single assessment framework was a great move to focus on integrated pathways. Some concern that moving back to sector specific inadequacy in marginalised groups might be widened. Consideration, a question around consideration of inspections of community services. A comment that CQC has narrowed down groups of concern and will new better regulation. Sorry, I can't see quite that answer. Let me just see if I can copy this somewhere else. Excuse me. Make sure I get this comment right. So there was a comment about narrowing down groups of concern, and will new better regulation provide better guidance for these groups? So thinking about people with learning disability, autism, mental health and health inequalities given the current state of care. I don't know if Toli, you have any reflections on that?
Yeah, some really good points coming through, aren't there, about the risk of I suppose what I've called siloed working, disproportionately affecting vulnerable groups covered by these protected characteristics. The issues around how we inspect. So one of the highest risk categories of patients, isn't it, is the patient who needs mental health care presenting to a type 1 ED in the acute sector. And they're probably there because of a breakdown of their caring community and no alternative about where else to go. And how does our inspection look at that individual and ensure that their care is safe? And it's patients who are at the interfaces of our sectors that are most at risk. And we have to guard against that siloed regulation, don't we? And missing that. So I think that's a really important point. How we would actually do it is, of course, we'd have an assessment framework for mental health, but we can apply that within an acute provider. And that's then where the professional judgment and expertise of the inspection team comes in, recognising that the acute provider may not be able to, won't have the same provision as a mental health provider, but still has to have a basic high standard of care for that patient. So I've seen some comments also, about sort of integration, 10-year plan and this move to, integrated health, neighbourhood teams. How do we regulate across that? So really important that we're thinking about that now, and that I think that one of the slides I said on it, about being future-proof. That's an area where we have to be future-proofed. As models of care change, how does our regulation take account of that?
Thanks, Toli. Also just want to bring out a point that I've scrolled to on the screen there that is about asking people who use services for their point of view. So for reassurance, we are doing that. So we've got representatives of public organisations on this call. We've got some in-person events planned in the coming weeks as well that will also include people with people that use services, and we've also run some targeted engagement sessions and have others coming up with experts by experience, people from seldom heard groups and people who use experience. So we're capturing those, we are capturing those views and including those people. So for reassurance that we are doing that. And of course the consultation is open to anybody and everybody to respond to, and we've had good uptake from public members of the public responding to the consultation as well, alongside providers and other audiences. So but thank you for raising that, because it's a key point there. Also seen some suggestions about focusing on particular groups. So there were particular suggestions in there that was really helpful to highlight those and make sure that we're looking at that. So more attention to elderly, marginalised, disabled and vulnerable. Any other reflections here, Toli, as things are coming through?
Yeah, so just you've got a comment now about people from minority ethnic communities who already face disparities and maybe further impacted if we don't take account of that. So for example, we're really conscious about the outcomes in maternity care for Black women and women from minority ethnic communities, and what in our regulation pays specific heed to that. So these are things we have to consider when we go and regulate. So for example, what is a provider doing about cultural competency in its staff? How is a provider taking account of the fact that we know these patients have much worse outcomes? What additional services are in place around that? How is the provider handling that? So these are things that we need to be alert to, and it's about our understanding and cultural competency as inspectors and regulators as well.
Thanks, Toli. There's another comment about making sure that reports are suitable to be read by all, and that is again another key point, and part of what we'll be doing next as we progress through the changes that we're making is exactly that. So engaging to make sure that all of our reports are accessible by anyone that needs to read them and use them to make decisions about their care or the care of their loved ones. I will move us on to the next question. So again, we will leave these open, and if people want to keep adding, please do. So the next question is getting into some of the specifics for this sector that we're talking about today. So what are the key things that we must consider when we're inspecting secondary and specialist care services? What must be represented in a sector framework? So again, if you could indicate the type of service that you're responding on behalf of, or the type of organisation, or if you're a person that uses services, a member of the public, that would be really helpful. And this is getting us into thinking about if we were to move to sector-specific frameworks or multiple frameworks rather than one single assessment framework, what do we absolutely need to make sure that we're representing? What are some of the unique issues that we need to be getting through that potentially has been lost through moving to one single framework? So we've got knowledge of the care that is provided, and I think that speaks to making sure that we've got the specialist teams and the expertise, and that comes back to the points about SPAs and making sure we've got the right inspection teams. There's There's a comment here from a NHS provider about making sure that the framework is proportionate across all multidisciplinary team members. So feels very nursing oriented now. Explanation of what we mean by secondary and specialist care. So Toli, I don't know if you could take this and just, this might be kind of internal CQC language, so just explaining some of the services that we will be looking at under this sector grouping.
Thank you very much for that. Yeah, so our sector covers our hospitals, ambulance trusts, and hospitals both NHS and independent. And we wanted to make the distinction between community providers. So there would be organisations that are called, community hospitals, but they would be regulated under primary community care. So hence the sort of qualification in brackets of secondary and specialist care. So the specialist being, it covers our ambulance sector, and then it covers those hospitals within secondary and tertiary care that are the specialist providers, like the specialist cancer hospitals and so on. I believe that the term hospitals, or my role, the Chief Inspector of Hospitals, was laid out in the original legislation. So it can't be lost because of that term, but we just wanted to try and be a bit more inclusive with our sector, because of course we include the ambulance trusts. So sorry for the long explanation, but that's essentially what it is. Again, while I've got the mic, can I just refer back to a point that flashed up in the last session? I thought was a really good point, a good challenge to me, which was when I talked about maternity outcomes. Why focus on maternity? Because we know people from ethnic minorities, global majority, have worse outcomes in all sorts of areas. Yeah, absolutely right. Our colleague who put that in there, and forgive my sort of slightly non-specific explanation. And you reminded me I need to be explicit about what I mean. The reason I cite maternity is there's a particular metric that's really shocking, which is maternal mortality. So death is pretty rare anyway, maternal mortality, but maternal mortality is nearly 3 times higher in Black women than in white women, which is really shocking. The discrepancy is so stark. So that's why it's been a particular sort of focus, because it's such an obvious area where it just shouldn't be like that. But you're absolutely right. It isn't just maternity, of course. Thank you.
Thank you, Toli. So we're having some good specific suggestions coming through. So another kind of nods to MDT approach and not all falling on particular aspects of the workforce. There's a comment here about as the NHS are going through changes in funding, providers are having to be more innovative with the care that they are providing. However, this does not always fall into CQC core services. How will this be taken into account when it comes to inspections? I don't know if you've got any thoughts on that, or if anyone wants to come in on that. I suppose this is a nod to how we as a regulator keep pace with changes in health and care. I don't know if you want to add anything to that.
Yeah, it's a really good point, isn't it? And I know we've sort of just said on one bullet point, we have to be future-proofing this, but you're right, it's for those reasons. So the provision of care, the models of care are changing faster than, than our assessment frameworks have been. And how do we consider that? The delivery of care is different. For example, so much more virtual delivery of care that didn't exist, really to the extent it does now, when we previously last reformed our assessment framework. So you're absolutely right. These are things that we have got to consider.
Thanks, Toli. There's a point around consideration for subspecialties as well, representing the diversity of the sector. The inspectors need to understand the specialties, and I suppose that's a question for us to get into through our engagement, and as we go through the detail, is what is the level that we need to go to, and making sure that we are reflecting some of the diversity and the expertise and the specialties within the sector. That's quite a broad sector. And I suppose to that point as well, making sure that questions are tailored to the clinical setting and clear on what is being asked. And some comments around the pathway as well. So just pulling out this comment here around not everything is within the provider control. The urgent and emergency care pathways heavily influenced by system factors, but that isn't always recognised. I don't know if there's anything here, Toli, that you want to reflect on in terms of how we're going to, how as a regulator we look across the system and how we're going to be working on that.
Yeah, that's a great example, the UEC pathway. And two parts to that. So in terms of the point you've raised, Sarah, about the system, the 2022 Act gave the CQC the powers to, I suppose, inspect, regulate, integrated care systems, but we haven't in fact done that as yet. So that's been paused because hitherto we've looked at provision of care, not commissioning, as it were. So that's just one factor in it. We haven't done that, but that is part of it. The other issue you raise, again, that's a really good example, because if you look at just ED in isolation or acute med in isolation, you don't get the full picture of why the quality of care is as it is in that area. So one of the sort of hot topics now that we reference in the state of care, and that is, a really important topic that matters to everybody really, is so-called corridor care, use of temporary escalation spaces. And that the use of a temporary escalation space is a symptom, isn't it, of the pressures the whole system is under. From our point of view as the regulator, though, actually, if you have to do that as a provider, how far are you going to keep that as safe and as compassionate and dignified as you can for the individuals you put there? So do you risk assess? Do you have policies around your risk assessment? What policies do you have around how those patients are observed, given their medication, given dignified privacy when they, excuse me, there's somebody at the door, but those are key points. Can you let me off, Sarah?
Yeah, of course. Okay, great. Thanks, everyone. So again, some really good and specific responses to that would be really helpful, and also seeing some points coming through that will be really helpful to inform the next kind of stages, as I mentioned, in terms of what is the level of detail that we need in guidance, what do we need to be making sure that we're linking to, etc. I will move us on to the next question, which is specifically on the proposals related to how we rate NHS trusts and some independent healthcare providers. So appreciating that not everybody here will be from a trust or an independent provider that this impacts, but there is obviously the wider perspective and view on this. So that's why we're asking this, because it's a specific part of the consultation, and really interested in people's thoughts on that. And just while people are starting to respond, Toli, I don't know if you would mind just recapping on these proposals.
Yeah, thank you very much. So this concerned, for example, an overall quality rating for these providers, not just the well-led assessment. It concerned whether, a trust should have individual ratings for the 5 key questions, the 5 key domains. I should just respond to a comment I saw earlier about independent health. Yes, in the same way as I mentioned about registration of social care, I should have made the point about registration for independent healthcare. These providers are businesses, so there is a wider impact on delays to registration for them. And whether you're NHS or independent, you are providing valued healthcare for this nation's population. So it's really important that we do whatever we can to facilitate your ability to provide that care. We recognise the issue about aged ratings. It impacts patients, whatever service they use. If the older the rating is, the less reliability they can place upon it to reflect the present day. So we do understand that impact. We're sorry that we have got these age ratings. in providers. We don't want that either. And we really do need to, very much increase our rate of inspection so that we can clear this backlog. And part of, if you look back at the Penny Dash review and the Mike Richards review, it talks about all of those issues. Thank you.
Thanks, Toli. So we have got some comments coming through around overall trust ratings being welcome. So an example here saying that doesn't always make sense that multiple buildings on the same site are registered and rated separately, and are welcome for it being reviewed. Some comments around needing to be clear on how those ratings are reached, and in terms of the independent sector, a view here that removing location level ratings isn't appropriate. So I think broadly welcoming the review, some kind of specific considerations in there that need to be kind of considered and brought in, and making sure that the descriptors to the public, so being careful on that and really clear, which is great suggestion there, thank you. Any other reflections on some of the points that are coming through, Toli?
Thank you. And I think some of the points there are reflecting the difficulty we also feel, the tension between location versus across. So I absolutely recognise that for independent healthcare, you're wanting location ratings. Patients don't, in general, I believe, patients don't look at a big group provider and care too much that it's a big group provider. They look at their local service and their local hospital. So in that sense, the location rating may be more important to patients. I'm qualifying that because we need to ask them what they want, not me speak for them. But I can understand why, and that's certainly the anecdotal feedback, again, that they care about their local hospital and they don't really recognise the organisational structure. However, providers have also said to us, and I recognise this as well, we, the provider, manage our services across a number of sites. Our staff work interchangeably across those sites. Our management structure manages all 3 sites. It's not helpful to us to have different ratings, just inspect us all as one service and rate us as one service. So there are arguments either way, and that's why we need the feedback on what's the best approach to take. Is it feasible to have a blended approach? Is it not practical to do that? These are the things we've got to think about.
Thanks, Toli. And I think that speaks a bit to this. Oh, sorry, Ruby, we wanted to.
Sorry, I was just going to kind of come in on what Toli said as well, just to kind of add to it. So I think definitely what we really want to achieve from this consultation is to really understand the different ways that care, in particular with this particular question in terms of how we rate NHS trusts, is to understand the different ways that care is being delivered, because we recognise there isn't a one-size-fits-all model. There are different types of models of care delivery and different ways as well that people experience care. So part of this is really trying to understand where the way that we currently rate trust works and doesn't work at the different levels of the way we've structured them effectively. So kind of sharing that bit of that experience with your responses would also help that, because we recognise, as Toli has said, when it comes to our location ratings, that one of the main challenges that we've encountered is in approaching these location ratings is the fact that it's not effectively reflecting where care is delivered across locations as well. So we know that care is not being delivered in just a vertical model anymore, and patients don't always access care in this way. So for example, a patient who's going to an outpatient's appointment and then is attending a few different services in the pathway across a few different locations in the trust which is an increasingly common situation. What does a location rating actually mean to this person and how they use these services? And does it tell them anything about the care that they're actually accessing? So there's something there about really trying to ensure that we are reflecting the different types of models of care delivery that people are actually experiencing. And then in terms of the trust level rating, there is something there around, again, just being sure that we can accurately reflect what quality looks like for a trust, what people are actually experiencing, and actually supporting the trust in terms of making improvements as well.
Thanks, Ruby. Any final reflections on this? Toli, anything you'd like to mention?
Yeah, getting some great feedback here, actually, really valuable to us. So thank you all for that. One thing did just catch my eye as it scrolled, and thank you for highlighting this. So quite rightly, there is an inspection team, and it's a multidisciplinary team. And when we talk about professional judgment, we must not give the impression that we're saying just one person makes the call on it and that's what it is. The professional judgment informs the overall decision, but it's the findings of a team and a whole load of supporting evidence that should lead to that better quality judgment. But yes, we can't. Please be assured it doesn't mean that we're going to say, okay, we rely on the opinion of one person. You're absolutely right. It's a team.
Thanks, Toli. So I think I'll hand back to Laura. We've had a few more questions come in the Q&A that we wanted to give some time to address. So thanks everyone for your participation in the Slido. It's a new way of us trying to engage with people online, so hopefully it felt okay and it was good to see what other people are thinking. As I mentioned, we'll leave those active, so I'll hand back to Laura to pick up on the Q&A. Thanks everyone.
Yeah, thanks, Sarah. A couple of questions that have got quite a lot of votes. One around, there's been no mention of must and should do's, and will these be returning? And I think that was also flagged by Gabrielle as part of her comment, and quite a lot of people have voted in that. Ruby, Maria, is that one for you or Toli?
I'm happy to come into that. So in terms of looking at what improvements we want to make to our methodology, part of that is also thinking about what we did before that worked well, that actually maybe this is something about how we can look to bring something back and make it better. We recognise in terms of shoulds and musts, these were obviously mechanisms for highlighting where improvements were needed and to help providers focus on where they can prioritise those making improvements. So we recognise how helpful they were as a mechanism. And so there is something about how we kind of look at that within the context of our wider methodology and where we need to make changes.
Yeah.
Thanks, Laura and Ruby. I just wanted to mention, I agree completely with Ruby on that. But in terms of framing must and should do's, I think it's probably helpful to look at musts as what is in line with the legislation and the regulations. So these, to me, are the musts. And the shoulds can be achieved in different ways by different providers. We do recognise that providers use different practices and different mechanisms for achieving great outcomes for patients. So we are quite open to recognising those differences. And I completely agree with a couple of comments that have come through in terms of improvements not being sufficiently recognised in reports and providers not receiving kind of that pathway to improvement that clearly. I think probably reports have focused a little bit more on the negative and have given a bit more of the picture of what needs to be achieved in order to move forward. But I think we need to get better at recognising what is working well and what innovative practice is being provided and how a service is improving its outcomes for patients as well. So kind of adding that positive narrative there as well. Hopefully that's helpful.
Thank you very much. Toli, did you want to come in on that before?
Yes, if I may. Thank you, Laura. Just on a couple of things. So, as I say, it's a consultation, and within CQC, we're a team. So I'm not trying to bias the team, but just say I personally like must and should, because I just think it's clear. And must's about breaches of regulations, and should is about, you know, improvement, but it doesn't constitute, it's not as, it would be disproportionate to say it was a breach of the regulations. I'm also very biased towards must and should, because, you know, in my times as chief medical officer, I was the responsible officer, and it became clear through dealing with, you know, doctors where there were concerns about professionalism, GNC and so on. You can't be woolly about, you know, should. And I got caught a couple of times on that, telling people you're suspended from the NHS, you're excluded from the NHS, so, you know, you shouldn't be going down your private provider. And then it being getting caught on, well, you said should, not must. So it made clear to me the importance of what's a must and what's a should, and where regulations are involved, must is a good word. The other thing also, just to refer to in the chat, is about the FACAC. So sorry we've not mentioned this. We sort of took it for granted, and you're right, we should not take anything for granted. We think it's really important that the factual accuracy check remains a key part of CQC's assessment framework. Providers have to be able to review the factual content of a draft report and challenge inaccuracies. So sorry if we weren't explicit on that, and thank you for whoever's flagged that.
Thank you, Toli. Another question we had from Gabrielle was around, will the reports be returning to a standardised PDF format? The current online versions cannot be downloaded and can be difficult to read due to the information being in separate sections. Anyone able to come back on that one?
I don't mind coming back on that. So I think it's really helpful feedback. The reason for how they're structured is partly due to accessibility. So we have accessibility guidelines that our website needs to meet. However, how we kind of publish reports is being looked at as part of this work, so we can certainly take back that feedback, because it's really helpful to understand how people use them and what they want to see from our reports. Thanks.
Thank you, Sarah. Really helpful. I think we've only got time for maybe one more question before I pass back to Toli, but something I have seen coming up a few times is about when are the proposals likely to be implemented and what is happening in the interim, which I think could be a good question to close on. I don't know who wants to come in on this first.
So we do have a time frame on it, and policy colleagues will know the detail on that. We're aiming to get our sort of draft, our first draft, by the end of January, and then we've got more time to refine, I think, through till about the summer. And then in parallel with that, we start the process of building our regulatory IT platform to accommodate how this would change. I don't know, policy colleagues, do you have the detail on that? Because we're seeking feedback again, aren't we, on our draft?
That's right, Toli. I think in terms of the complete approach being in place, we're not looking at sooner than 2027. However, next year, we're expecting to be able to publish something in draft format and to continue gathering your views via different channels. We're also expecting to report back on the consultation results, as well as on those engagement events that are currently taking place around summer next year. So hopefully around that time, we'll know what people's main views and concerns have been. And we hope to have something on the website that you can engage on further and comment on in terms of the frameworks, how they're structured, what they look like, so that you can see in practice what we're talking about in terms of those commitments. And whilst doing that, we're taking into account everything that people have said in the consultation, as well as in engagement with both our internal colleagues, but also external stakeholders like yourselves.
Thank you, Maria. That's really helpful. If nothing else on that, I will ask Jay to share the slides and pass back to you, Toli.
Brilliant. Thank you so much for that. This slide really just summarises what Maria's just said. But I think the important thing for me is that we genuinely want to co-design this. We will not get it right on our own. We know already where we've not got it right before, and we do not want to make that mistake again. So we genuinely want feedback, and we're really thankful to you all for giving us that today. We have got a final closing slide, haven't we? But really, this is just our opportunity to say to you, please come back on the 11th, by the 11th of December, if you have further feedback to give us, either through the website or through the QR code. What we've had from you today has been absolutely tremendous. Thank you so much to all of you who've made this time, taken time out of very busy diaries, I know, to give us this hour and a half. And your active engagement has been terrific. Loads of questions, loads of feedback through the Slido comment, and I promise you we will look at every one of those items. So thank you so much for giving us this time and helping us get this right. As I say, we have a shared commitment, don't we, to the population of this country, the public who support us, who use our services, and as providers and regulator, I know we are committed to this being as good as we can possibly get it. So thank you for your help with that.